And the people that are having problems are saying they can't
Yeah,
authenticate to get in.
that's what it is. I don't know what's going on. I don't know if it's the Zoom link. Um, but I'm just, if you could, I don't know if there's
I
something
think
that you
it's
can
the Zoom
do.
link. Sorry, I had problems signing in and had to go through a whole bunch of different steps this time to get in, and I finally did.
Oh, okay. I'll just let Fernaz to keep trying. She's another one that couldn't get on. Sorry about that.
I had an issue where I wasn't logged into Zoom, and then I logged in with my personal Zoom, and then the link worked. So I don't know if that's the issue, if you just need to be logged into something, but just putting that out there.
Oh, all right.
Thanks,
Well,
Anthony.
we're apologizing for all of the difficulties with the technology, but we'll try to do better next time. So for those of you who are still trying, I hope you are able to get back on or get on and join us. Just want to send out a shout of thanks to Iger Barron, and he is one of our, I believe, PTs. He got raving recognition. I'm sorry, my phone is just going crazy. He's got raving recognition for all of his wonderful care that he gave. This patient happened to call back 3 times just to send out praises about he and his services to ACE. So want to give a shout out to Iger. If you're on, congratulations, and you'll be sent a small reimbursement for that. And we want to thank you all for just being a great team. We have grown by leaps and bounds. You know, I believe we almost have twice the census that we had 3 months ago, and we're expecting that we will continue that growth. So it's probably going to be a few bumps and what do you call it? Some edges that need to be smoothed out along the way. So just be patient with us as we continue to grow. And with that, I'm going to give it over to Joey, who's going to talk about our company update.
Thanks, Tanya. As you know, while Tanya was talking, I was just kind of flipping through and seeing who was here, and I tell you, I was just beaming at the newness of some of the folks, and also seeing some people who were here before I even got here. It is clearly a mixture of people that I've met over the years, and they're good people, they're great people. I'm going to especially mention a couple. Avi was here. Avi's our OT, and Avi actually helped with my training when I first moved here from Texas, and I even reminded Avi that the first time I saw him, he was wearing a brown North Face jacket, which I've never seen before, and I was impressed with it. And then he told me to stop reminding him he's still wearing the same thing, during the winter time. So Avi is one of the people that convinced me that this company was well worth staying at. So thanks to Avi. And then of course some of the new people that I've met, Sherry and Garrick and Tiffany and all of you guys. It is just, I am so happy. Avery, Vince, I am so happy to be part of this group. You cannot even imagine. I count myself blessed every day to be part of this group. So on now to the company update. Obviously, you guys know that we have a hospice program. And yesterday in the office was really a noisy day in the office. We haven't had that anything like that since the pandemic started. Both upstairs and downstairs conference rooms were full of people. Upstairs there was a home health aid in service that was going on. They were loud. And then there was a rehab competency session that was going on for folks that needed the competencies done. They were also loud. And then downstairs was really loud because we were saying goodbye to a couple of our hospice LVNs that are starting their RN program. So it was amazing seeing so many people here. It reminded me of the days when this two-story office that we're in was full of people. But our hospice program is growing, continues to grow. Great feedback from referral sources, from facilities that we serve patients, from patients and the families. And you know, we actually have an opportunity to expand our hospice program as well. And we should get that done before the end of the year. So we're excited about our hospice program. The next one is our care management remote patient monitoring. As you guys know, we actually put that service on hold about 2 months ago, 3 months ago. We're not deleting it. We're not getting rid of it. We've got it on hold. We're actually starting to put places back in already to implement that specifically for our home health program. We believe that that will help with our care management of patients better, and something that I'm going to touch on later. And now on to home health. Phew, as Tanya said, home health over the last 3 months has really shifted. I'm seeing, in fact, I just saw Mary Yee pop up. I haven't seen her in about 3 months. Said hello to a couple of folks earlier from our San Jose, Santa Clara team. Shraddha, I know, is part of the call. We have changed so much in terms of the areas that we cover, and also in terms of the type of patients that we serve. At one time, we only had one team in terms of scheduling, intake, QA, and clinical team. Now we have three, and this has all happened within the last 3 months. Kaiser used to be 70% of our census 3 months ago. As of today, it's now 25% of our census. The Medicare and Medicare Advantage census is about 50%. As Tanya said, about three months ago, our census was around 300. We are now in the mid 500s. It's a significant growth over the last 3 months. During that time also, our hospitalization rate has gone up, okay? Our utilization per patient numbers have gone up. Essentially, our visit number per episode has gone up. And during that time, our outcomes, our scores on outcome measures have declined. This is based on the OAS data sets. So we have to ask the question, are we providing worse care to our patient? And the answer is absolutely not. We're not doing that. I know the kind of care that you guys are providing because we have stories. We hear stories from patients and their families of how great you are. What we learned over the last 8 years being a Kaiser Divert agency is that their care management of patients is really, really good. It's really tight, sometimes too tight. Tanya and I will attest to that. When we first stepped into our roles, many of you guys don't know this, but about 4 years ago, when Tanya and I stepped into our roles, for 6 months, we would have a morning call that would last from 8 to 12, sometimes 1, to discuss our entire Kaiser census. Every patient we had to talk about with Kaiser. They wanted us to really manage their patients well. What we also know with Kaiser is that their outcomes, based on the OASIS data points, is very good. So we have this, this interesting imbalance. Kaiser reduces their number of visits, but the case manage their patients really well, and they get really good outcomes. What we've noticed over the last 3 months is with the Medicare and Medicare Advantage census that we have increasing that way, our hospitalization rate has gone up, like I said, and our outcomes has gone down. So to us, it's about quality of care. And we're learning from Kaiser on how to case manage those patients well. And we created a quality improvement, a quality care program. And this is just to offer clinical pathways, best practices on how to manage patients with specific diagnoses, specific conditions. We want our patients to get better as soon as possible. Here's the other thing that you guys should know as well. There are two types of payers. One is the episodic payers. These are like Medicare. They give us a bundle amount of money to manage cases. And then there are the per visit payers, the Kaisers, the Alameda Alliance, the Contra Costa Health Plan, county payers. Those folks, and all of them, not those, but all of those payers have their own utilization management, utilization review teams. And after we've discharged patients, their UR teams will look at cases and determine if we provided more care based on the outcomes that we got. And you guys should know that sometimes we actually have to pay back these money to these payers. We have to do a refund because they say, well, we did, let's say 15, 16, 17 visits, but over the last 3-4 visits, nothing was really done. There was not any more education, outcomes weren't improved, blah, 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 blah. So they'll say, look, you guys owe us 4 visits. You got to return that back to us. Essentially, they're saying you should have stopped it at 13 because the outcomes are the same. So those are the things that we actually have to contend with. And Kaiser has known this for many, many years. And that's why they forced us to case manage our patients better. For us, it is about patient outcomes. And it's about serving you guys, equipping you guys to get really good patient outcomes. And that's what we're going to do. We're going to support you guys better. We know the kind of people that you are. I've had a hand in interviewing many of you folks here. And I've interviewed probably twice as many that I said no to. I know time is the same, and the people who have done interviews have done the same. We are not about hiring people with great clinical skills. That is a big plus for us. We're about hiring people, adding people who have great character, and great personalities. That's who we are. That's why at the beginning I said I enjoy coming to work, because if I get a chance to work with guys like Ray and Art and Joan, and Danielle and Mitch and Lede, and I get a chance to do that. It's total joy for me. So I want to end with thanking you guys for making my job the best in the world. I've enjoyed my time here, so thank you. Tanya, back to you.
Okay. We just want to say that we really appreciate you so greatly, because you're the ones that make the agency happen. If you don't do the visits and you don't provide quality care, we just go downhill. But our star rating keeps going up. We went from a 3.5, we're now a 4, and our goal is to become a 5-star rating agency. It's not impossible. We're already on the trajectory. So, congratulations to you that make it happen. We're going to go now to Akila Ward, who has several things to talk to us about: health navigation, documentation submission, and calling of MDs. And she's also going to prep you for a new role that we have with wound care management. Akila, take it away.
Hi, everyone. So I am on my phone today because I'm having computer issues. But when we send out the face-to-face, you guys will have my presentation with that. Can you guys hear me okay?
Yeah.
Okay. So I just want to start off. This will be a verbal conversation, so you guys chime in with any questions or concerns that you have based on what we talk about. So documentation submission, we have noticed lately that the timeliness of documentation being submitted has gone down. And so I wanted to take the time to remind everyone that payroll is dependent upon your documentation being submitted. If there's anyone that's having, you're slow or because you're new with the system or you're confused with anything, the quality coordinators are a great source they'll set up a Zoom with you. If you're still not getting with them, feel free to reach out to myself and I'll set up a Zoom with you to do some access training and to go over any questions you have with your documentation. But it is very important that you guys are getting your documentation submitted no later than Monday. at 1 p.m. as it will impact payroll and your paycheck if your documentation is not submitted. So I just wanted to bring that up to everyone. That is something that I will be focusing on over the next couple of weeks, is reaching out to folks. I started this week, reaching out to folks to see why their documentation is behind, if I'm able to help, and what resources you guys need to be able to submit your documentation timely. The other thing I'm starting off with the more not so positive notes, and then we'll go to the more positive ones. So calling physicians. With our increase in Medicare, what we've come across with Kaiser, this was not really an issue. But with our increase and with Medicare and other insurances, what we're coming across more is the problem of physicians telling us that they are not following a patient. So when that happens, when we're 2-3 weeks in to seeing a patient, that's a clear indicator that the physician's not being, can be a clear indicator that the physician is not being contacted at start of care. So I just want to reiterate to everyone that it's very important that you guys are contacting, calling the doctor after your start of care and reporting the open. You don't have to wait for the doctor to call you back, but leave a message letting the doctor know that you've performed the start of care, what your interventions are for that patient, what you'll be working on. If they have any issues, to please give you a call back within 24 hours. Otherwise, you will be submitting an order for their signature. If the doctor is not following, they usually will call you back and let you know, I'm not following this patient. It's usually when they don't call you back that, all is well in the world. So it's very important that you guys are calling after your start of care or resumption of care to inform and research to inform the doctor that you've opened that case or recertified that case. If you're having any issues with, a wrong number for a doctor or, any type of issue with a physician, please let intake know. And what they'll do is work on finding a phone number or a fax number, or, if it's not the right physician, between intake and the marketers, they'll work on getting information for a new physician. Okay. Any questions with that thus far?
I'm sorry, Akila, you did indicate that we have to call that physician at the start of care, correct?
So
Notify
really,
them?
yeah. So start of care, resumption of care, and recertification, it's imperative. Obviously, whenever we're obtaining an order, we're calling a doctor. But it is very important that you guys are making sure that you're making that call and leaving a message, letting the physician or the physician's office know that you have opened that patient to home health or recertified the patient to home health. Okay. Okay. So as Tanya indicated, we are rolling out a wound care consultation program with Joan, who will be helping us lead that. And essentially what Joan will be doing is we will identify patients whose wounds have declined or they've stalled. And she will be prioritizing those patients to do joint visits with clinicians. So she will be reaching out to you guys. She may have some pre-visit questions, reaching out to schedule with clinicians. It is important that you guys are getting back to her and setting up the day and time for your joint visit. The initial visit will be joint so that she can see how you're performing the wound care, determine if there's any education that you may need, any resources that you need, and just get an idea of where you guys, each individual is with their wound care processes. After the initial visit, we will follow up within 2 weeks, but that will be a PRN visit that she will use, and the clinician does not have to be there at the visit. Okay. At any point while she's following that patient, if she identifies that there's more educational need, there may be another joint visit that she'll request, but that will be the exception and not the rule. And so it'll just be the initial visit that she will do a joint visit with the clinician, whether it's the RN or the LVN. Our goal is to, have better outcomes with our wounds, and also to make sure that clinicians are educated on wound care. There are some clinicians that wound care is not their thing, and that's fine. However, you still have to be able to identify wounds and provide the proper treatment, even though they may not be your thing. So Joan will just be a resource for you guys for wound care. You don't have to wait for her to reach out to you if you have a wound that's declined or stalled. You can reach out to her and ask her for help. You can send her pictures. You can do a FaceTime with her and have a meeting with her to go over the wound care in regards to your patients. Outside of doing the joint visits and actual in-person visits with patients, Joan will also start to do some wound education for us. Our goal is to do a quarterly education in regards to wound care, and that's for nursing and therapy, to really help clinicians be able to identify the staging of wounds, proper treatments, and things of that sort. Tanya, did you have anything to add?
Yeah, she will also have the ability when she's doing these visits to change the treatment orders, put those MD orders in. But the big payoff on this is that, she also will contact the physician
Mhm.
and obtain that order, as well as what are the supplies for you for Medline, through Medline, so that that takes that responsibility away from you for that moment. And then as you implement the new order, she will follow up and make sure that the wound is progressing. And there's Joan. Take it away.
And
Yeah,
just to
oh, go
I'm sorry,
ahead.
sorry, John, just to add real quick, this does not disrupt when you guys do your joint visits. It's not disrupting the clinician's pay. So the clinician will complete the documentation, will get paid their normal revisit rate. So it's not disrupting anything when you guys are doing your joint visit together.
Good
Sorry.
to know. Go ahead, Joan.
Well, I'm happy to have this new role and assist people with their wounds and educate. That's one of my main goals, is to educate everybody into knowing how to really properly handle their wounds, and when things aren't healing, to change to something else, but also to look at all the confounding factors that caused the wound in the first place. We can't just focus on the wound itself. We have to concentrate on what caused it and what we can do to heal it holistically. So I'm happy to be helping, and please reach out to me if you have a wound that you need help with. And we're going to be going through the list of all the wound patients and seeing who's priority. So just give me an email.
Okay, that's
Oh,
great.
and our class, our first class, is, I understand it, is going to be on July 20th in the office.
That's correct. And that's for all the nursing staff other than the CHHAs. And there's a question. Michelle wants to know, are you available for weekend visits? She's our starter care nurse on Saturdays.
Well, I try really not to work on weekends. But I mean, I'm sure I can see the patient after,
Yeah.
we can figure something out that weekend start of care.
Yeah. So she says she's totally understanding, but what Michelle can do is just, upload that picture, send it to you, and then you can do a follow-up visit on the week and then do your consultation and get back to her, which is
No, that's a good plan.
yeah, I think that's really super. So I'm very excited about Joan's new role. She's an expert in that field. She's one of several wound care specialists, but that is her passion and desire. So we have promoted her as such to be our wound care specialist, and that's going to be her primary role.
Yeah.
So congratulations, Joan, and we look forward to your consultations. And we appreciate the ones that you have done in the past, but we're expanding that role.
Thank you.
And
Yeah.
just so you know, we'll also record the educational classes that Joan does. So, that way it's available to those that only work on weekend and are per diem.
Yes, and I'll have handouts too that we can also put online for people to refer to.
Mm-hmm.
Okay, that's excellent. Well, we're really moving along very quickly here. Today will be a short meeting.
We'll tell you one more thing.
Go ahead.
So our last, just closing out for myself on a positive note, is we are going to, over the next month, be piloting a health navigation pilot. And essentially, Joey spoke a lot about utilization and outcomes and patient care and support for staff. And really, this pilot encompasses all of that. So what we're going to attempt, and we'll try it with two, we're going to start with two people, with each person being assigned to 3 to 4 clinicians. And essentially what that person will be to clinicians is I'm calling it a clinical associate or a clinical assistant to you guys, where they can take off your plate some of the non-patient, direct patient care related items. So for example, calling your patients and setting up the schedule, doing a pre-visit telephone visit to find out what's occurred with that patient since your last visit with them. Ordering your Medline supplies for you. There'll be clinicians, so they'll be able to call the doctors for you, to either report things, or let's say you want to obtain a new order for, a frequency, just for as an example. They'll be able to assist you guys with things, to take off your plate some of the items that are not directly patient related. They'll be able to, if for those that choose, you can call this person after your visit and verbally give them the information for your visit note, and they can type it in for you in that moment. So we're developing what that role will be, but the ultimate goal is that it's someone that can assist you guys and again take off of your plate some of those things that are not directly patient related, patient care related. We will also be rolling out, our QA coordinators will be focusing more on your guys' plan of cares, how you're answering your OASIS, and utilization. And that's another program that we'll be rolling out, starting next week, over the next month as well. And so you'll start to get more, less visit notes sent back and more questions about, the RN opened the case, but the PC indicated on their functional scores that the new items are scored differently. And really just encouraging the communication and collaboration, as well as Joey said, the managers will be meeting, to go all over all the cases, identify the skilled need, looking at the care plans, and we'll be providing information back to them, which will be a guide for them on what they're looking for in each of your cases. The managers meeting will also trigger us and, be the guide for us on what patients will do case conference on directly with clinicians. So our QA process is going to become more focused, and then our pilot program will be to help you guys and take some of those things off of your plate.
I know you guys are looking forward to that. Less calls to the doctors, less time, doing the busy work, care authorizations, all of that. That is just time away from attention that you can be focused on for your patient care, and actually just really focusing on your quality of your documentation, which we all can improve on. It sounds like some of you would be very excited to have this program on board. And once you see how it works in terms of the pilot, we'll be rolling that out to everyone. So I know we're looking forward to that. So
Yeah.
I'm going to try to, go ahead.
Sorry, we just have a question. From Michelle, can you please review the best way for obtaining an advance directive when the patient doesn't have a copy but says it's with their doctor's office? So we can call the doctor's office to see if we can obtain a copy of it. We can also assign an MSW. Sometimes they're not clear on, they think they have one that was done 5 years ago, they're not sure. So we can also assign a MSW to the case to help them, with an advance directive or their ed post, and getting those completed as well. Hopefully that answered that question.
Sorry, had to catch a call. I just want to ask everyone, kind of want to take you guys off mute. In terms of the documentation, I know this is kind of a Pandora's box, but I'm going to actually ask for you guys to respond. Tell us what are some of the things that we know offhand that get in the way with you submitting your documentation timely? We can tell you what we know, but I want to hear from you all. What things really get in the way?
Well, I can speak that just sometimes, I know that I'm not the only one that's voiced this concern that access is particularly difficult to organize your thoughts because there's so many boxes everywhere. So it's sort of hard to remember, okay, what did I put, like, especially during your evaluation, there's like the OASIS ADLs and then there's the functional ADLs. So you got to remember, like, what did I put on the previous boxes and does it match this one? And then sometimes it's really easy just visually because it's a little bit cluttered to like see, did I do everything? So even if we submit the note within like 24 to 48 hours, like often I get a lot of things back. So then I have to go through and redo those. And sometimes I don't have time to do it that day. So then it's the next day. So then that's what kind of leads to like the 4 to 5 day turnaround sometimes. I think it's a combination of like access not being super functional and then also just getting those notes back. I don't know if it's possible for the QA team to actually fix some of those things and submit it without us having to redo it ourselves, or like if it's like a non-clinical judgment thing where they just saw something was left blank. Obviously, if it's something that needs to be done, like that wasn't filled in and they have no idea what's going on. But anyway, that's just my 2 cents on it.
I appreciate your feedback. Is there someone else?
Hi, Tanya, it's Yvonne.
Hi, Yvonne.
My concern with Access is that some OWL will be charting and then it needs to update. And then, you have to wait for that. And it kind of gets me out of the gets me out of the mood because I'm working and I have to save it and then chart it. And then it's just like, okay, well, I have to wait like 45 minutes for it to update. So this is on the laptop, not on the phone, on the laptop. So I kind of, okay, I'll just get back to it tomorrow because then other things happen. But it usually happens like around like 7 or 8. And I'm like, okay, I'm just gonna just turn it in for the night.
So how long does it take to update? Because when I've been on it, it takes like about 30 seconds and then I'm in.
Well, my laptop, like I said, takes about 30 minutes. I'll keep refreshing it. And then I'm like, okay, I'm not gonna wait anymore.
So I've talked to Access about their updates. They usually do them Wednesday night into Thursday morning. It's either Wednesday night into Thursday morning or it's Thursday night into Friday morning. So then there's really nothing we can do about that. I don't know why it's taking yours 30 minutes to update because I'm with Tanya, like when the update comes, it takes like 30 seconds and then the update's gone. So I'm curious, is anyone else experience updates that take up to 30 minutes? Michelle said I experienced that too. Okay. I can put in a ticket, I guess, Yvonne, the next time it happens. I don't know, maybe take a screenshot of when it starts or when but I'll call Access and put in a ticket.
Keely, it's Michelle. I was responding.
Go ahead, Michelle.
I was responding to another question. I'm not experiencing what you're experiencing, so I just wanted to clarify.
What was your question?
I'm not experiencing that delay that Akila was mentioning.
Okay.
Yeah, I was in the chat. I was responding to another comment.
Oh, okay. All right. Anybody else want to respond to the documentation submission delay?
So Tiffany said her mic's not working, but she said, I chart in the app. It doesn't copy when I log into my laptop to chart. Also, Wound Manager doesn't work, which makes me delayed sometimes.
So I've experienced that too, Tiffany. So I can speak directly to that. And what I do is I'll copy and paste, like for instance, the summary that I have that goes into the MD order and also goes to the SOCROC team to show that I've opened the patient. what I do is I have to copy and paste it and put it on a separate document. And then I can then save it and then put it back into Access, like into my email or into an MD order. It doesn't copy directly, you're right. But I did a workaround, and it doesn't take that long to be able to just, bring up Microsoft Word, put it in just a new document, and then cut and paste it and put it into your MD order or the Safra email. It's worked for me.
So I'm sorry, just to clarify, so you guys are saying when you start a note on the app and then go to finish it on your laptop, the note's not pulling up on your laptop?
I had that experience this week where I had started a note on a patient, and then sometimes on the app, I have like an Android tablet I use in the field. It stalls out and it won't let me continue documenting, and then I have to close it. And this time when I went back in, even though I had saved the other work, my vitals were gone. I had to redo the whole note on my laptop. So this was my first experience this week of having that happen.
Okay, I'm putting a ticket for that also.
Oh.
Also, I have one more small comment. I promise to keep it brief. I find that it's a little frustrating when we're starting like our first follow-up visit, that all of the things that we put into our evaluation aren't automatically put into the first revisit note, like what their ADLs were during like their functions and all of that kind of stuff isn't like good to go. So we have to bring up the old evaluation and then kind of like copy paste. And so it's just a little bit time consuming versus other platforms that I've used at other companies that just kind of have that good to go. And then the same thing happens again when you do a discharge note. It's completely blank, so that you need to kind of look at where you were before on another document instead of just kind of updating things. So it's a little bit more time consuming.
So once you do get it in the revisit note, though, you can recopy it from there.
Yes, that's correct. It's just the first revisit that you've got to do, and then if there's a reevaluation, then I think you actually can use the first evaluation. I'm not sure on that one, but then the discharge note again is completely blank. So each of those times it's kind of like you're starting over from scratch, or you got to bring up another document on another part of the screen and then copy paste, which is a sort of like laborious when we could be using that time to be, seeing patients or something.
Yeah.
Go ahead, Akila.
No, I was gonna say, unfortunately that function. Oh, go ahead.
No, Kila, I have a question after you talk.
Okay. That function is there with the Oasis. You're right that it's not there with the eval. The ADLs won't copy that you put in on the eval won't copy over to your revisits. And I guess I wouldn't want them to, because each revisit is an assessment of where they are with their ADLs at that time. So.
Well, my argument would be that like when we have to do the assessment below and we have to do like progress and all that kind of stuff, you still need to see what the levels were before. So you're going to have to either change what they were, or you're going to have that document side by side. But I think it's just quicker because they don't always progress in between everything, every single visit. So that's just my 2 cents. It's a lot of extra copying, pasting, and having multiple things up. It just is more time consuming.
I definitely see it with the discharge. I think it would definitely be helpful to have that with the discharge. Don't know how successful we'll be with getting that changed, but I can definitely request it.
Can I, Akila, on that same note, when you go in and you do an initial evaluation, like you have the Oasis levels presented there, could we have something set up maybe in that capacity where you can see what was on the evaluation, and then you could make any changes into the new note or the discharge? Do you know what I'm talking about?
Yeah. I'll put in a request. I don't, I can't promise that they'll take action on it, but I would definitely put the request in.
I'm sorry. This is Anne. May I have a quick question also? Yes. So I usually get the QA returning my follow-up visit. on the ADLs and the IADLs. I mean, it's not an exercise, but sometimes there's the box for the repetitions. I mean, I cannot document how many times they do toilet transfer or, dressing that. And also some of the choice for the adaptive equipments are not even applicable. Like, if it like dressing, but it show, like walkers or canes, but if there's no choice to click none, I usually have to put it in the comment box, but usually the note get returned because I, didn't pick the adaptive equipment or put in how many times they did it.
Okay. Adaptive equipment and repetition. Okay. Let me
Akila,
look at the returns. Yeah.
Akila,
Mhm.
Akila, about the apps. When I'm trying to click the patient and then map, the app is throwing me off. So I have to do manual enter to my GPS. Is that something you can also ask them what's going on?
Okay. I'm sorry. Repeat. What was the problem?
So with the apps on my cell phone,
Uh-huh.
and then I click the patient and then their address, and then suddenly the app is throwing me off. I have to log in again.
I had to delete the app. It was doing it for me all day yesterday. I deleted the app and re-downloaded it, and it fixed it.
Yeah.
Oh, okay. Thank you.
So typically, if you're having issues with the app, the first thing to do is check to see if there's an update. And sometimes we'll do the update, but still, like, I'll have to go in and delete the app and reinstall it after they've done an update. The other thing is that if your phone, like if you're, I think right now we're on Apple, the 16 point something. If you're on 15, it's going to impact how the app works for you. So it's doing the updates on your phone as well as the updates for access.
A lot to keep up with. I got it. There's
Yeah.
one other question, and Sherry Stallman wants to know if there's something being sent back from the QA team. Is there a live person for them to talk with?
Yeah, so what you can do is you could just email the QA team and ask them that you like to set up a Zoom or a telephone conference. And they'll, whatever your schedule is, they'll work with you on setting up either a Zoom or a phone call to answer any questions you have. You can also reach out to myself if you have any questions about access, or really if you guys are getting things returned and you're not understanding why, or even if you're frustrated with the QA team, like send me a screenshot, text me a screenshot of what you're frustrated with or what you feel. Because sometimes, it's like, why do I have to do this? And sometimes they've been directed because we're having compliance issues or because it came up via survey, and so they're asking for it because we've asked them to do it, or that's something that they need to be monitoring. And so I can, better help you guys understand. Or if it's something like the adaptive equipment, right? I'm going to look at it, and if I'm like, it's not really necessary, then I'll just go back to them and let them know, hey guys, don't bother anybody about this adaptive equipment. And then it solves your problem of getting something returned for that.
So I'm gonna ask this too. On the little red flags where they have delineated what you need to correct, and I know I tend to have conflicts with what their conflicts are. Is there a way to like cut and paste that so you can put it in email and then discuss it with them over email?
For the QA team or for the clinicians?
For the clinicians to be able to discuss that without having to call them.
Oh yeah, I mean, yeah, you guys can do that as well. So there's, we try to do it the least. We've gotten complaints from clinicians when they get emails. We've gotten complaints from clinicians when they don't get emails. So really, your team is designated a QA coordinator. So if you're talking to Charmaine, she's the QA coordinator for your team. So really specify to her what's your preferred method of communication. If you'd like her to return it and then send you an email to let you know the items that she's returned and like give you a list of reasons why, let her know, because she's there for compliance for the documentation, but she's also there to help make your guys' lives easier. They all are. So whatever is the best method for you in helping you to get that note fixed and returned or completed, just let your designated QA coordinator know.
Hi, I have a quick question.
Mm-hmm.
I don't interrupt though. Just about the communication aspect.
Uh-huh.
I'm just wondering if there's a better, more efficient way to communicate with each other. Like if we had a group text where every clinician that's assigned to that patient, where we can update each other in real time. Like where I've showed up to a patient's house where the nurse was also seeing that day, but they weren't home. It would be helpful if I could just, with a, in 3 seconds, where I could just send a quick text versus looking up their phone number or sending email. And sometimes when I send an email, accidentally, or someone responds where it only goes to me, or instead of the whole group, or I respond back and it only responds to one person instead of replying to all. It would just be easier where you can see a text, okay, a text notification versus an email, and you don't necessarily know if the email is, something, important. Or even with visit times, like, oh, I'm actually running a little bit later, a little bit early, and I see you're seeing the patient this day. What time are you, I could be there in 15 minutes. While we be overlapping the visit, just for something that's really efficient, where it could just be really quick. Or something was like, really important with the patient, you wanted to just communicate right away.
Yeah, so we used to use Tiger Text and we stopped because folks would do things like, state whatever they want to state, and then it'd be like, great, thank you. Yeah, you're welcome. Okay, have a great day. Yeah, you too. And in the meantime, you've got 10 people attached, right?
Yeah.
Thank you, you're welcome. Have a great day. You too. And so people started deleting the app and not utilizing it. However, we have implemented with our sanitary team an app called Lark. And so we can re-implement that to all the staff to utilize. So, but I will just, and we can do that starting this week. It's just going to be important that you guys, you'll get a link to make sure you click the link to set up the app on your phone. And to make sure that, we limit the have a great day. Thank you.
Yeah, just make it critical information, not, pleasantry type of
information about the patient. We don't need a thank you. We don't need a great day. We don't need a, smile faces. It's just about the patient care. So that way everyone will stay on it and respond to it.
Perfect. Thanks.
Okay. Thank you guys for your feedback, and we'll try to improve upon the things that we can to make your lives easier as far as documentation as well as communication. We have a gentleman by the name of Brian Hicks. He's from Care Builders, and I'd like to turn the meeting over to him so he can discuss his business with you about patient care.
Good morning, everybody. And I'm actually gonna keep this pretty short because I think you guys know care or home care businesses at this point. But I'm gonna say, we've gotten referrals from ACE in the past with some of your cases that needed continuing care beyond the services they're receiving from you. And oftentimes we end up in a situation where they just can't afford it. I think you guys know that scarcity breeds inflation, and as prices continue to go up, we really end up pricing out a lot of our community members who need the care. They just can't afford it anymore. So we've been kind of going round and round on how can we make this work a little bit better so that when you guys have cases where people need some form of care, we can adjust a little bit. And, you probably know home care companies are looking at 8-hour minimums in a lot of cases, 12-hour minimums, just because the demand is so high. We're a little bit lower than that in that we look at 4-hour minimums, but even that has been problematic at times for some of the cases that have come through to us. So we're looking at something called personal assistant services. I'm going to share a screen with you, and I really wanted to use this time to get your opinions about doing something like this, if it sounds viable as a way of kind of referring additional services when you have people who need care beyond when you're providing it for them. So let me see if I can pop it up there again. And this kind of gives a rundown of what we're actually looking at. We're partitioning out what we would normally do on a group basis. So we would do personal care visits, transportation, housekeeping, and wellness all in a single shift. And what we're trying to do is get it down to where we're doing 1 hour cases for people when they need them, which reduces that cost pretty significantly. And it really kind of sticks to what they want specifically in terms of assistance during the day. Pricing is going to probably end up somewhere around $75 an hour, just putting that out. We haven't figured all that out, but finding a way to make the caregivers interested in doing this kind of case and also trying to keep the price down is where we're trying to get that balance at. But I'd say roughly somewhere between 70 to 75 is what we're thinking of for a 1 hour visit. But I think what we really want to know is, with something like this, where we're really partitioning out the types of services that we're doing and being specific about what a person needs, do you feel something like this would be applicable in the cases that you're working with? And I will say again, we've gotten referrals from you guys where, we went in, we talked about the minimums, and we said, okay, there's a 4 hour minimum, and we got a lot of pushback that I don't really need somebody for 4 hours. I want somebody for 1 hour or for 2 hours. And oftentimes I think it's just a response to, the cost of services. But I wanted to get an opinion from the clinicians online. Do you feel like this is something that would be useful, not really that you're interested in, would it be useful for you? And if so, we would go ahead and continue down this path and create a pricing structure and create flyers and everything. But, the main thing is to find a way to provide that care to some of our needy community members who don't want to spend $4,000 a month or whatever the amount is for home care. They need something that kind of fits into their budget. So with that, I just want to open it up and get some feedback on your thoughts on doing something, going down this path.
Well, I can say that I know personally that if you have like 1 or 2 hours that it's just for personal care, it's a lot more affordable than having a group of 4 hour window for, a lot higher or twice the price, and it be a lot more affordable and probably then more accessible for our patients who have less money to spend on these things, but still need care.
I think that's really what we're looking at, is how to make it accessible. I mean, we have a business that's really built on a different type of model, and that's going, and I always challenge our group, how do we find ways to make certain that we're not cutting part of the population out as home care prices continue to climb? And we're doing everything we can to keep it down, but knowing that the cost of caregivers continues to go up, there's always a challenge. But if we can find a way to dial back that minimum and break this up so that if it is a personal care visit and someone just needs a bath and to get dressed and it's going to take an hour, let's do that versus saying we need you to take us 4 hours a day for 3 days a week, and that's a higher cost. So you're right, it's the accessibility piece we're really trying to appeal to here.
Yeah, we have somebody in the chat that says they know a lot of patients who could use these services, just for a one-time thing.
Yeah.
So we'll definitely have your brochure available for our clinicians to have and to to give out to our patients as they require it.
Couple of ways. There'll be a single visit type of structure we'll put together. If it's something that they want to do on a monthly basis, we'll put together kind of a monthly package of X number of visits per week, and just to kind of give the option to them so they can choose what's going to work for them. But I do think it extends us to be able to meet the needs of that community member who doesn't have endless resources to spend on home care, but that have that need for somebody to come in, when they can no longer get those services through home health. So I think we'll kind of move ahead. I think really you guys hear where we're coming from on this, and I'll go ahead and put a program together that includes pricing, and we'll kind of like pass it through to Joey and Tanya again, just to make sure we have everything polished off. And then if it sounds good, we'll make the brochures, and we're going to keep it pretty much in the Alameda County area at this point. That's where our primary footprint is. And, we basically will tie a short hour shift in with one of our existing cases. And so that's how we really plan to make it useful for the caregivers. If they can get an extra hour and, it makes sense for them, they'll do it. If we send them out into, somewhere where we don't currently have a client, and we're just paying them for a 1 hour shift. That's not going to happen. So I think sticking it to our care line, our client lines is what's going to be important here. Okay. I'll say if anyone has any questions, I'd be open to answer those now. I don't want to tie up too much of your time. But it's a very specific program, though, that we're looking at.
Okay. Well, thank you, Brian. And we look forward to getting that brochure and passing it out to those people who are of need. And I think, with the different ways that you have the package, it'd be a lot more attractive to our patients.
Yeah, it just really breaks apart what the needs are and keeps it limited. So I appreciate the time, everybody. Have a great day. And I was listening to some of your conversations. We talk about the tech and we talk about communications all the time. So you guys actually gave me some good ideas I can go back with our group on. So keep up the great work, and I appreciate the time.
All right. Thank you again for your time.
Bye-bye.
Okay. Now we're going to go ahead. I'm going to try to share my screen. Okay. Let's see. Can you see my screen? I'm going to try to get some of these things out of the way. Yes or no?
Yes. Yes.
Okay.
Yes.
So the first thing I want to talk about then is in terms of medications. We're always in Joint Commission prep or CHAP prep, as it is towards the end of the year. We're going to be going towards a CHAP certification program for next year. But they're pretty identical in terms of the type of goals and necessities that we have to meet for our patient that we serve. And one of them is based on the National Patient Safety Goals, and that is nationwide. As you see, it's, they have identifiers. That's the first goal, to improve staff communication. We talked about that. To use medication safely. Of course, prevention of infection, and I feel like number 6, which is new, to identify patient suicide risk, and of course, making to prevent mistakes in surgery. We have nothing to do with the surgical part, but we have a lot to do with everything else, including alarm safety, which I will go into it another time. But I'm primarily directed at using medication safely. We tend to then kind of skirt around this, and that's one of my goals, is to try to increase our medication reconciliation. And so I'm just going to click on this other document, if it will come up. There we go. Is our medication policy. I'm not going to go into a whole lot of detail. It's 2 pages long. But I just want to identify the salient points. One is to make sure that we are complete and accurate when we're doing all of our medications, whenever we do them, particularly at the start of care, at research and recertification, but also weekly. You understand that is our policy as a home health agency, that new and changed meds are reconciled on a weekly basis. And you get notes from the QA team, I know, to say, have you checked it? And if you haven't, they make you or force you to at least sign it again, your med profile. But I don't want you to do this just routinely by the fact that QA will then ask you to do it, but then you don't actually sit down and go through the meds, because it's pointless, right? If you're just doing it because it's a knee-jerk reaction, we're not really delivering safe care of our medication profiles during our visits. So just want to re-emphasize that. But it also includes making sure that you go over the side effects and the contraindications. And I'm going to close this now and see if I can go to my other document. Let's see, the patient satisfaction survey. So we have this HICAP, or the patient satisfaction survey. And do you realize there are at least 5 questions on the survey? that are related just to medication. So question 4, when you started getting home health, did someone talk to you about prescription and over-the-counter medications? Number 5, when you're getting home health from this care agency, did someone ask to, quote, see all of your prescription and over-the-counter medications? We want them to answer yes to both of those. Then you have down in the next section, and number 12, in the last 2 months of care, did home health providers from this agency talk to you about the purpose of these new or changed meds? Of course, we want them to respond yes to that as well. And then on, 13 and 14, in the last 2 months of care, did your health provider from this agency talk to you about when to take the medications? And 14, the side effects. So you've got the side effects. You have when that you're taking them, the purposes of taking them, the side effects, over-the-counter meds, as well as prescription meds. And I think most salient point for me is 5. Did the agency, from the home health agency, did they ask to see all of the medications? So I don't want a show of hands who actually do all of these components, but it should be all of our clinicians who have a license, other than the home health aides and the MSWs that do this. So it's a very important thing. It's a very important in terms of safety and care of our patients. And it's on the survey. So if they answer no to any one of this, that's a big thing. Let me go again here. So I just want to emphasize that we also have this brochure. If you can see that, Kaiser gave it to us, and I have it available in the office, and you have a soft copy that I've given you in the past via email, and we'll send it again. But these common medications and side effects is a really quick way to dialogue with your patients about the type of medications they have, what their names are, alternate names, and the possible side effects, and they group them. And so this is a very easy document to use when you're going through your medication reconciliations to identify all of these action purposes, side effects that are requested on the patient survey. So please utilize this. All right. The other thing, let me hold on 1 second, is I have a little quiz. Let me see if I can find it. 1 sec. Let me see if I can find that medication quiz. I'd like us to do this quiz together, if I can pull it up. Hold on 1 sec. Here we go. Oh, nope. Give me a second. That's not it. Forgive me. Give me 1 second. See if I can pull it up. It's not there. There it is. Okay, here we go. All right. So you guys can take yourselves off the mic, and or you can use the chat box. But I have 5 questions that we can all do as a group. And I want to make sure that we are proficient at answering them. So question 1 is, what would you include in your following med profile? And the answers are Pepto-Bismol, over-the-counter Tylenol, fish oil, and probiotics. Which one would you include? Or
All of the above.
All of
All
them.
of the above.
Thank you very
All of the
good.
above.
I knew you would be able to get that. Okay, now this is one that I did before. Let's see if you can catch which one is correct and which one isn't. So, which of the Tylenol orders is written correctly? And I'm not going to give you any hints. I'll give you hints afterwards. So A is Tylenol 500 milligrams. 1 tablet, 6 hours is needed for generalized pain by mouth. Tylenol 500 milligrams, 2 tablets every 4 to 6 hours for headache, fever, or mild pain. C is Tylenol 500 milligrams every 4 to 6 hours is needed. And D is Tylenol 500 milligrams, 2 tablets daily, PRN, headache, fever, or mild pain.
D.
The first one.
A, first one.
Yeah,
A.
Yeah, you
the-
want
A.
how they're taking it.
All right.
D.
So A has all the components that is necessary for your correct medication profile
Wow.
because it includes the medication, the route, it gives the frequency, and instead of PRN, it actually gives the explanation of the type of pain and the mechanism for it to be delivered. So A is the correct answer. So those who said A, you're great. All right. 3, how often do you check new changed or expired medications? Every visit? At the SOC, ROC, or the at the, I'm sorry, recertification? Weekly or never?
Every
D.
visit.
Every visit.
Every visit.
So I like every visit, but you know, our policy says B and C at the start of care, resumption of care, recertification, and weekly. But if you're doing it every visit, you're going to hit it. So I love A, B, and C, but I never, absolutely never. Okay, so here we go. How do you proceed with medication reconciliation? A is compare a list of discharge medications to the patient list of medications in their home. B is use the discharge medication list from the MD referral to all of the containers, creams, inhalers, over-the-counter prescription medications in the home. C is guess. D is inquire about unusual places in the home where medications might be stored. So there might be more than one answer.
A and D.
Excelente. Absolutely. Because if you don't inquire about those unusual places where the medications might be stored, you're going to miss something. Very good. All right. 5, last and only. Where or in the home would you inquire that the medications might be stored? And you may have additional answers to this, but A is cabinets, B is by the bed, C is over the countertops, D is in unopened bags, and E is in the bathroom.
All of the above.
Can you think of more?
Kitchen cabinet. Well, cabinets, but
The fridge.
The fridge.
fridge.
Yes. Okay. I think that's great because yeah, there's a you get eye drops in the refrigerator, and you get usually insulin. There's certain medicines that have to be stored, and like IV antibiotics, correct? So the fridge is another place you want to inquire. So thank you for much your attention. We're actually going to close early unless there's any other further questions.
Hey, can I just clarify for the medication profile? So you guys should be asking if there are any changes to their meds every visit, but you don't have you sign the med profile weekly. So the QA team is looking that you sign your med profile at least. Someone signed it at least weekly.
Yeah, and that's in the medication policy.
Yeah.
Very good. Thank you for emphasizing the positive. And looks like we got a lot of people in the chat. Somebody said plus the fridge. Thank you, Melissa. So thank you so much for your attention. We appreciate that you've taken the time out, and we're going to give you time off early.
Wait, Tanya, one more thing. I'm sorry, you guys. I just wanted to clarify, we talked earlier about QA focusing on the OASIS versus the evals that are done. I just want to remind therapy that when you guys are doing your eval, you can see what the mood items that were answered on the OASIS. What we're looking for is for you to, guys to indicate a different number if you don't agree. So if the nurse scored it as a 2, you think it's a 3, that you change it to a 3, because then what we'll do is go back to nursing and help with that collaboration to potentially get that answer changed to a 3 based on PT or OT's expertise.
Sounds good. Okay. Any other, anything else we can address a concern, about concerns?
Sorry, Akila. So if we need to change the nurse's score, who should we email? The QA or you?
Change it in your eval. So in your eval, the OASIS scores are there, and you guys are able to change it. So if you see that they scored it a 1 and you think it's a 2, just change it to a 2, and the QA team is looking at your evals to see if you scored it differently than the nurse did. And then they'll
So we don't need to email. We can just correct it from there.
you can correct it from there, yeah. I mean, you can feel free to
Unfortunately,
in on your own, but QA will also be looking at that.
so Akila, how many days are we allowed to change it? Just within 5 days?
Correct. So within 5 days, however, the coders, part of what they're doing is they're auditing that OASIS. So they may come back to you guys on week 3 and say, hey, you know, these two answers contraindicate each other, and so there's corrections that can be made after the 5 days.
Because I'm sorry, because it happened to one of the patients and I corrected it during the eval. Unfortunately, when I discharged the patient, the score is still the same what the nurse put in. So yeah, that's a conflict.
Yeah, so this is part of the more detailed audit. We're going to change our focus in the QA team to start focusing more on that. And so that should have been going forward. The QA team, they're in training right now. So in the next week or 2, you guys will start to see their focus switch from your revisit notes. They're still going to review every wound care revisit note, but there'll be less focus on your revisit notes unless you're a person that struggles with the revisit note. They'll maintain focus on you, but there'll be less focus on revisit notes and more focus on the OASIS and the therapy plan of cares or evals.
All right, thank you so much.
Okay. Thank you guys for your feedback and appreciate your attention. Have a great day.
Tanya, Michelle has her hand raised.
Michelle?
Yeah, I'm sorry. Akila, could you just explain that further? Because if my assessment is different, I'm wondering why I would need to change it, because that was my assessment of the patient's status.
So OASIS allows collaboration. And so physical therapy will tend to, so let's say that, you know, you're 1840, 1850, you may have assessed, but physical, you know, OT may have come in and actually had the patient transfer into the shower using a transfer bench. And, you know, that's their level of expertise is at that assessment. So collaboration is allowed on the OASIS. And, you know, whereas yours may not have been as a detailed assessment as theirs, and actually having them do that transfer. So they may have witnessed that while the patient says they can and the caregiver says they can, when they were there, the caregiver had to basically lift them up and transfer them to the shower chair, right? And thus they would come back to you and say, I don't think that they're one. I really think that they're, based on my assessment, they're really this.
What is the issue of the nurse leaving their assessment as that? Was there a problem? Did we get dinged? I'm trying to understand why we are needing to change our assessment. I understand collaboration, but it's still, that's something that I'm signing that was what I assessed at that time.
So the rules of OASIS is that it allows collaboration, because basically what we're recognizing is that if the PT or OT did their evaluation within the 5 days of your open, their assessment could have been more in depth, more in detail, a different level of expertise. And so that collaboration can influence changes in the OASIS because again, you're relying on their level of expertise and recognizing that it may be beyond yours in that particular mood item.
And if I can chime in, it's not to denigrate what nurses do, but we tend to, again, that's not our area of expertise in terms of functioning. And our nurses generally tend to rate our patients higher than their actual ability to perform these functions. And it is not our area of expertise. So we defer that to physical therapy to help us in that area where we have that weakness.
And also, can I share? Sometimes when the nurse go in, the patient just came home from the hospital and they're using a wheelchair. However, patient is really able to walk. So the nurse will click a wheelchair. But if the patient is walking, before we used to have with the Vero, we used to have SHA. If the patient is walking, you should have click the wheelchair section. So that's a
But I would
too.
see that as the patient had progressed from the time that we saw. So I wouldn't say that that charting by the nurse would be incorrect, because if it was post-op, yes, they might be relying more on assisted devices. But I'm assuming there had been time that have lapsed between the nurse SOC and then the PT visit. So you would assume that they would increase their activity level, but that does not mean that the nurse's assessment was incorrect or needs to be changed.
So if it happened with a 5-day period of your open, you know, if you go today and PT goes in tomorrow, and with their assessment, they're having the patient get, you know, asking the patient to get up and walk 20 feet, or there's certain assessments that they do that nursing doesn't do, and the things that they assess for, the nursing doesn't assess for. It's very unlikely that between yesterday and today, they've progressed from being wheelchair dependent to being able to walk. So it's not, again, it's not degrading what nursing has done in your guys' assessment skill. It's just that PT and OT use different assessment tools that could lead to different responses based on, because that's their level of expertise and the tools that they use. I guess we could say would be more reliable in regards to assessing the patient's true function levels.
I wasn't seeing it as like saying that our assessment is wrong. It was just more of accuracy in charting, where that was my assessment at that time. And I'm not relying on anyone else's assessment because I wasn't there during. So it was more like independent practitioners, independent clinicians charting on their own assessment is kind of like, is what I wanted to bring up.
Dependent upon an independent person's assessment. The OASIS is dependent upon collaboration amongst disciplines. And that's why the rules of the OASIS are that collaboration can occur within that 5-day time period. Because they're recognizing that there's different disciplines coming in with different levels of expertise using different assessment tools. And thus, after collaboration, and within that 5-day time frame, answers may change. So the OASIS tool is not an independent tool. It's a team tool, I guess you could say.
It's more collaborative, is what you're saying.
Okay, thank you so much.
Any more before we close out? Because I can't see everybody's hand up. If not, we'll go ahead and say have a great day. All right. Thank you again for participating.
All right, guys. Thank you.
Thank you.
Tanya, can you stay?
Yeah, I think you wanted a team to stay on.
Yeah, it was Monty, Kai, and gonna stay on also. I don't know if she's on though.
Akila, do you want me to stop the recording for this part?
Yeah.